And what we did in that study is we took the clinical variables that are used, so what is called the FLIPI, or the Follicular Lymphoma International Prognostic Index. And it is a set of clinical variables that are used to inform outcome. And it works quite well in almost all treatment regimens in which it's been tested. However, it doesn't help one be able to plan a therapy. It just provides an expectation of survival or outcome. So what we did is we actually sequenced at pretty good depth 74 genes, and we did this in a discovery cohort, and then we validated an independent cohort. And we could show in that study that we were able to identify approximately 25 to 28% of patients who had a markedly inferior survival that was not predicted by the clinical FLIPI. So suddenly now we have a tool that could be applied. This was done, by the way, using routinely available paraffin blocks. So the original diagnostic blocks were what were used to extract DNA. And when we did that, we actually distilled down to 7 genes that, when combined with the FLIPI, could identify this markedly inferior subset. That immediately provides a tool that people could then use going forward, could be used in the context of planning clinical trials, or even used to enroll. So what you'd be able to do is identify those patients who are destined to do very poorly quite quickly. That would also allow us to do trials where we're not waiting 10 to 15 years to see differences in outcome. They would occur quite quickly. So that's an example of a tool in the new molecular era that could actually penetrate clinical practice. It's done using routine material. It sounds complicated. I mean, in the original work we actually sequenced quite a few genes, but in the end we distilled down to 7. Some that were associated with favorable outcome, and some that were associated with inferior outcome. But together in a model with the FLIPI, they were highly predictive of survival.